works. All right, everybody, we're gonna attempt to get started. First and foremost, a shameless plug. If any of you have missed a lecture and you really want to see Luke Smith talk over and over and over, he is immortalized on this website, nypem.net. Don't be confused, it's actually slightly different than nypem.org, which is the team site. But if you want to watch lectures, great. The other function of this site is if you want to share something or post something, if you want to become St. George and make a Google blog, booklet, flip something, you can send it to me and I can post it up here essentially like blog style. That's my shameless plug. All right, so if you could all either pull out as well, all super easy, and we're gonna play a little game. I'm Justin, by the way. I'm one of the second years. And hey, I'm gonna clarify. So this is like normal IV, like you're sort of stabbing in the dark. You think you feel something, you think you see something. TLC, 1011 care, that can be a double or triple lumen, I don't really care. It's just the long, small tube you stick in someone's neck or groin. Yes.
What access do you want?
We're gonna go through some scenarios. An ultrasound guided IV, we'll assume it actually works. And then we're gonna go real generic, a sheath introducer, think large tube, relatively short, in a big container. And then an EJ, if you're feeling it. All right, so give you a few more seconds. So we'll give you a nice. Well, this is good now. It tells me it works. We'll give the first case something basic. So 50-year-old gentleman comes into the emergency department and he says, I'm on metformin. I was supposed to go to insulin. I decided I'm not going to take any of these things. I've been feeling nauseous and vomiting. He looks really dehydrated. His pH is 7.0, but he's walking and talking. Not well, but he's walking and talking. What kind of access do you want for this guy? You get 30 seconds for technological humans here. All right, we see a trend. So most people just want a regular old-fashioned IV, probably be a little bit aggressive bear to putting an IO in the guy. I don't think he's necessarily bound for anywhere where he would need a triple lumen catheter. That's fine, that's fair. What are the goals of this patient? What are you trying to do for this guy? GB, what do you want to give this guy?
Fluid.
Anything else?
Because that is not consider bicarb.
Sure, so fluids, bicarb, insulin, basic stuff. You're not giving him anything fancy. How many liters are you going to give this guy? GB. A ton. 4 or 5 liters. Do you have to give it to him in the next 30 minutes? Probably not. Right? You got some time. So regular old IV might work. Dear internet. Promised myself I'd be better at the technological stuff. Give me 30 seconds. We're going to reset this. All right, next scenario. Give you some time to think about it. So, pregnant female comes in. She's pale. She's tachycardic. She's hypotensive. She is what you would say looking like death. Let's take a few moments, think about what you want, and we're going to reset this. All right, so actually you can actually just clear your old response. I forgot about that. That's what I was going to do. Clear your old response and just re-answer it. So now adjust. So she's hemorrhaging from below, she's pale, she's tachycardic, she starts to pass out on you, epoch hemoglobin says 4. Now what do you want? Okay, so about a third of you said sheath introducer. Why?
Larger.
What's the benefit?
Can give them more blood faster.
Okay, and why is that?
Faster.
All right, short large tube, and we're going to go over why that helps. All right, so what is your goal? What are you trying to do for this person? You're going to give her
Blood pressure.
blood. You're going to give her blood, or she's going to die. So you need to put blood into a human being. Triple lumen catheter may not be your best bet, and we'll remind you as to why it's probably not your best bet. Last case. So again, you can remodify your thing. So morbidly obese, African American, diabetic, incredibly thick skin, chronic hospitalizations, has cellulitis in random parts of their body, open lesions, and they come in anaphylaxis. Like full-blown anaphylaxis. Their throat is closing. They're like, they have no mental status. They're not protecting their airway, and even the best ultrasound guided IV may be difficult on this guy. Imagine like a huge dude, and he's kind of like, nah, and there's blood splashing everywhere. What do you want? All right, so we're moving towards a different answer, right? So what's the correct answer for this scenario? Does it matter if it's an IV? Does it matter if it's sono-guided or regular? Does it matter if it's a sheath in his neck for all I care? No. It's literally whatever you can get in first. And a lot of people put IO. But I remember my first time trying to find an IO in Colombia, someone says, go get the IO. And you run away instinctively. You get about 30 feet and you're like, crap. I have no idea where it is. I have no idea what it looks like. But I can't go back because now I've already run in a direction. I have to commit to this direction to do a whole kind of lap. You're like, hey, where's the IO? Where's the IO? And then you finally open it up and there's 3 sizes and you go, I don't know which one to use. And you arbitrarily pick a needle and then you kind of stand there waiting like, now do I go? Now do I go? So all that matters is whatever you can do fastest. So the point of these questions is that there's a variety of how we approach vascular access. And we'll go through a bunch of things, most namely how to think about it in general terms, because this would be literally the worst talk in the world if all I did was go over central lines 10 times in like a 30-minute span. I think we'd all have a stroke. So this is me. I'm a person. We're going to start with our take-home points. So 3 big take-home points. Prepare. And that means a lot of things. It's not just setting up your tray in a nice, beautiful fashion, organizing things alphabetical by height. That's just one tiny step of preparation. A lot of it is thinking about what you want to do for the patient. A lot of it is getting the patient in the right position. And the other component of that is practicing. That either on a simulator, when we have those noon conferences and we crack a kit, actually fiddle and play with the stuff. When you find the little tube and you're like, what the hell is this tube? Look it up. Find out what that tube does. See if it benefits you at all, or can you literally just take it out of the kit and throw it in the corner and have one less thing on your field. The other thing that's important is anatomy. And I remember opening, an anatomy textbook, first year of medical school, and everything's in like 2 dimensions. They try to draw things in 3D, but it's not all that helpful. And when you're going to be putting access into people, you have to think about more than just a 2-dimensional picture, because you're sticking an object in 3-dimensional space into another object. And so it helps to think about the things in 3 dimensions, and just reviewing the anatomy of common places you're going to put access into. You don't have to know every anatomical site in the body by heart, but if you're going to be doing something a lot, or if you're going to be doing something in the moment where you don't have time to prep or think, those are the things you should probably know the anatomy relatively well enough to do the task. You don't have to know every facet of the arm if you're just going to be sticking drills in a certain portion of it. And the last thing is physics, because I'm a giant nerd, and I want to go over a lot of the misconceptions in just fluid flow and how it applies to medicine. So we're going to go over preparation. So why am I doing this? So when you're going to stick a needle in someone's arm, neck, whatever, you should think about why you're doing it. Is it to give medications? Is it because the floor team insists they have to have an IV to go upstairs and they're refusing the patient otherwise, even though that makes no sense? You have to decide why you're doing it, and that will help guide you with what tools you're going to use, where you're going to put it, and how long do you want to leave it in. Where are you going to put this? So, say for example you're putting in a central line. Not a billion options, but you got a few. It's important to think about things beyond just the anatomy of where an object's going to go. So if you're putting an ultrasound guided IV in the arm, you got to think about convenience. Can a nurse get to it? If a nurse can't get to your IV because it's tucked into their armpit and the person's morbidly obese, it's not going to help you in an emergency. If you put it in a joint, somewhere where they're going to bend all the time, it's probably going to fall off, or they're going to fall asleep with their arm bent, and you're not going to get any of those 5 liters that GB's ordered for you. So you gotta think about the mechanics of where you're putting this thing. I'm amazed the number of times I see lines placed in parts of the body that have a local infection. It happens much more often than I thought it would, or there's some sort of skin lesion on the top where I probably wouldn't want to be introducing that into the body, and it happens a fair amount. The other thing to think about is left versus right. Doesn't matter. In some things like a central line in the IJ, it may matter because it's a straight shot down versus having to loop around and you may end up in the arm. Those things are more obvious, but a lot of people have contraindications, and if they're out of it, they may not be able to tell you. So go looking for fistulas, look for other reasons why you would or wouldn't pick a certain side. And a lot of times people are so obsessed with getting a line in the neck that like there's 10 people around the chest and the neck and it's crowded as hell, that from time to time you're gonna have to weigh the benefit of, is it just worth it to go into the groin? Is this person crashing now and it's not worth me fighting next to the airway person for what I need to do, which is probably just as important, then I need to do it somewhere else. So just thinking about where you might put things in advance of doing it. So knowing your tools. Can anybody tell me what this guy is? Someone says cordis. Any other answers? This drove me crazy when I was an intern. Go get the cordis. And there's no cordis. Nothing says cordis in the supply closet. And then in the ICU in Cornell they say, go get the arrow. And you can't find anything with the word arrow on it that isn't like an ABG arterial line stick kit. So this is actually a European brand of what we all call a sheath introducer. So it's basically just this section of tube that you're going to stick into somebody, and all these kits have essentially the same stuff in it. You got a needle you're going to jam into somebody, a wire you're going to put through that tube, and then a dilator and a catheter. And there's 5 or 6 brands in the United States that make these things. So my attempt is to get away from saying cordis, arrow, I think this is like AccuTube or something nonsensical, and just call it the sheath introducer, so that if somewhere on the kit it says the word sheath, it probably will work for my function, which is I want to stick a large tube into a big blood vessel. That's all I want to do. I don't care whose brand I'm buying, but just know that these names are different, know what a brand is, know what the generic name is. And I had to look this up like 5 or 6 times to remind myself. I kept looking for cordis and I couldn't find it. And that drives you crazy. The IO gun. So there are, especially in peds, there's actually different guns and there's different like hand tools, and a lot of them I'd never seen. And there was a patient who died in the PICU, and apparently they tried like 3 or 4 times to put in an IO, and they were using the guns, and the baby's bones were so soft they just kept drilling through and through, and there were like 6 of the manual drills, but no one had ever used them before, so no one knew what they looked like. They're like these gray sort of like oblong, like grippy, spinny things, and like I had to like hold it up and be like, how would I? If you've never seen it before, when it matters, you're not going to be able to put it in. So the first time I put in an IO, they were a huge person, so I grabbed the biggest needle, so I was very lucky. I had no idea what that tapey thing did, and the person was so obese that I had to like push through all the edema, got into the site, and as soon as I walked away and connected all the tubing, it had basically been pushed out from all the fat and the edema, and it was no longer working, and I didn't know, could I put it back into that same bone? Do I have to switch sides? Crap, I don't have any more yellows. So now what do? I need to go find a different part of the body and use the blue and see if I can find a skinnier part of the person. But if you, like that hesitation where you stand there with the drill and you're like, I'm not sure, do I just go? Is it kind of like here? Those hesitations are specifically why the IO gun was made, so that you don't delay in getting access to give these patient meds. So if you've never drilled a hole in someone's bone, get one and drill a piece of plastic, drill a piece of rubber. Get through that manual motion of doing it so that when it matters, you don't delay. And it's just a comfort thing. All the triple lumen catheters, I think we have I counted 7 different brands. They're all relatively the same. The length of them and the pressure rating are the 2 biggest things I found to be important. And anybody who I think is ever going to get an imaging study, I make sure that it has a pressure rating, or it's a power pick or a power central line, because that's the worst thing in the world, where you put a central line into somebody, but you can't use it for any imaging modality. And apparently they only cost an extra $1 or $2, so there's no reason to not just stick in the slightly thicker plastic tubing into somebody. And that was the big thing I learned as an intern. And then just being very comfortable with your IVs, the range, who should get what, does it really matter? And this will be more important for people whom you're putting an IV in them when they're a hard stick, and you're not so sure they necessarily need the IV, but someone's demanding it, or you just need to give them a tiny, fluid bolus, or you give them a tiny amount of medication. And for patient comfort, if you don't need a 16 gauge, put in a 22. We're not here to be jerks. So pick something that's appropriate for the situation, and get very comfortable with other IVs. I think we have the nice little auto collect ones. I went to another community hospital where they only had these manual guys, and I remember standing there with the needle being like, wait, what do I do with this? I can't put it on the bed. There's no sharps container. Where do you stick a pointy object that has no retraction to it? In the mattress, that could work. I might forget it. But it's something just to be used to, that your brand of IV may not be the only one, and know the limitations of each of the sizes, and we'll go over each of the limitations. And the last sort of basic thing in preparation is positioning. If anyone's ever seen me put an ultrasound guided IV, I spend about 10 minutes setting up, but I also haven't missed in 60 patients. And I spend about 10 minutes mostly just putting their body at a height where I'm super comfortable and I'm very relaxed. So I'm not bending over, I'm not leaning back, I'm not doing left-handed lines if I don't have to, and I put a lot of padding under their arm. I lift their arm up. I make sure that everything is set up in a position so the person sits perfectly still, tolerates me taking my time, and isn't going to flail around once I do the initial stick. And my success rate skyrocketed when I just put them in a position to not squirm, and put myself in a position where I'm standing, I can see my screen, left hand and right hand are all relatively in a 20 or 30 degree view. Sometimes in Columbia you don't have a choice. You're leaning over one patient, left-handing, while the probe is over here, and you're looking behind you and you're doing this. That may be the case at times, but if you have the space, you have the time, set it all up. And one of the best places to do this I found was in the MICU, where people had central lines needed to come out, and I would spend forever looking up and down their arms and finding the best possible target and putting everything in different positions to see how I was comfortable, and find your own groove for how you want to position people. Most times I see people fail on procedures. Things are spread out, they're trapped in a corner, they just look uncomfortable, and I think that's a huge contribution to why we screw up, because the physical task of sticking a needle in a tube is actually relatively easy, but if you're uncomfortable, it just increases the odds that you're going to make a failure at some point. So now let's talk about anatomy. Not every single anatomical point in the world. So there's, I think, 6 acceptable places you can stick an IO. And you look at these pictures and you're like, okay, so it looks like they're sort of pointing towards just below the knee. It's great. If my patients are translucent, then this is going to be great for me. I can see the bone and I can just stab it. But a lot of people, you don't know where you're going. And so, you stand there with the drill, you stand above their leg and you think, okay, I'm kind of aiming here, so I'm just going to go. If you ever think you're going to put an IO in, take the time and feel the person's leg. Feel the arm. And you can do this with yourself. So feel we'll say your left leg, just below the knee. And feel where the bone is. Find the tibia. Find the tip. It's like a triangle. So you find the top of the triangle. And if you can't remember if it's medial or lateral, check both sides. For most of us, when you feel the medial side of the tibia, there's a big flat surface. So for me, it's this thick. It's 1.5 inches. and it goes for about 6 inches. And it's a big, big flat platform. And so from time to time, when I'm thinking about doing an IO, I'll often just touch my own leg and be like, so that's where I'm gonna go. It's gonna be medial, it's gonna be kind of into this direction, and if I can't feel the anatomy on someone else, I have to have some way to remind myself. And so that's what I found to be really useful for IOs, is thinking about where would I put it in myself. Imagine the person, if I can't see their anatomy, that's probably where I would go approximately. And the other thing is, can anyone tell me what this guy is? Riding around a little curve. I'll give you a hint, it's related to the biceps muscle. Some sort of tendon looking thing. So apparently people actually drill into this all the time and sever it. And I didn't know that until the IO people were like showing me how to do it. And one of the first things they tell you to do is thumb to bun. And I was like, well, like, why does that matter? And they like pull out a picture and they show you it and they go, okay, well, if the person's arm is out and you drill in right here, you're gonna go right through that tendon. And I had never thought of that. I think I put in like 6 or 7 in someone's arm and I've never ever rotated their arm or even known that that was a thing. And so I feel kind of bad. Like, did I sever somebody's biceps tendon? I don't know. I probably wasn't thinking when I was putting it in. But that's just one of the things you can think about. So for every procedure, review what anatomical things matter. You don't have to know every piece of anatomy, but that seems like a pretty important thing to know that no one ever told me. So for any procedure you're gonna do, think about the contraindications and think about the anatomy you're really trying to miss. Some things are obvious. Sticking a needle in your neck. There's probably a few things in there I want to avoid, right? But there may be other access points where there are other things you're trying to avoid. Fun fact, you don't need an x-ray after you place an IO. Again, no one told me this. After I IO'd people, I kept getting x-rays of the parts I was IOing in case I had fractured their bone. Apparently that's not a thing. And this is super cool. So your anaphylaxis dude survives, then AMAs 4 hours later, and comes back. You probably can't use the same site again. But if he comes back the next day, by all means, drill in the leg again. You can reuse the same exact site 24 hours later. Hopefully that never happens, but it's an option. So more of just anatomy in 2D. So you're like, all right, well, I read a textbook and I saw that like the vein is medial to the artery and the femoral nerve, artery, vein, navel. Cool, I can remember all that stuff. In the neck, there's a whole bunch of gibberish. In these pictures, it looks like my IJ is outside and slightly in front of my carotid. So I'm going to memorize those things, and that's how I'm going to distinguish where stuff is. And we're going to come back to this. So I got these giant 2 vessels, and I want to stick something inside them. So how are we going to go about doing it? So this is more of the geometry of putting a tube into a tube. That's essentially all you're doing. Literally the worst thing in the world for me to do is to give you a talk on how to put in a central line. So we're going to skip that entirely and just go into, these are all exactly the same. So you're going to put a needle into a space and you're going to put a catheter over it, either with a guide wire or not. That's how all these things work. You're sticking a tube into a tube. So think about the 2 different aspects. What do you think it looks like from the side? And what do you think it looks from the cross section? And it's not going to be an ultrasound concept, but that's how you should be thinking about these 2 things. So one is the angle of attack. Big dramatic angle of attack. The top picture is the bevel. So for the longest time, people always say bevel up, and I had to Google what that meant as a medical student. And it wasn't until I watched like a slow motion animation of someone placing a central line that I realized you're actually cutting. You're making a linear cut with the bottom part of that bevel into any tube. So having the bevel up, you're still making a cut, you're just making it on a slightly different plane, but then you have all that resistance behind it. Probably isn't good for the vessel you're stabbing into, because your goal is to get into that tube without shredding it to pieces. So going through and through a bunch of times, you're probably shredding that vessel to pieces. It's not gonna last long. And if you're going at such a low angle of attack, you're like trying to be super graceful about it, you're probably just scratching off the entire top portion of that vessel. So just think about the angle of attack. They all have pros and cons at different angles. The most important angle that I think about is if I'm putting an IV or a central line or something where I think I'm going to go about 35 to 45 degree angle, I'm putting my probe down, I'm looking at this 2-dimensional picture, but I have to think about the other axis that I can't see. Because what I see all the time is people put an ultrasound probe down and they stab right by the probe. That's great if you're going straight down at like 85 degrees. Fantastic. You're going to see your needle right where you're stabbing in. For the vast majority of the time, the probe should be away from the needle. One, because that's not sterile when you're doing ultrasound IV to be stabbing right next to the filthy, dirty probe, which probably hasn't been cleaned. But you want to back off a bit. And the distance you back off, we have this wonderful thing we learned in middle school, where the distance between the skin and the vessel, that's a distance, that's a number. We're going to call that X, we're going to get old school here. And then the distance you would want to back off if you're going the prototypical 30 degrees is a little bit less than double that distance. So if you're sticking in a super deep line into someone's upper arm, you may need to back off a decent amount. And the reason you do this is so that you know how far you're going down, you have your needle, and instead of like inserting like a centimeter, looking around, panning, scoping, centimeter panning, scoping, centimeter panning, you should find what your target is. Where do you want to actually puncture the vessel? Know how deep you're going, what angle you're going, and back off so that you push it in one swoop, torture the person less, and you're much more likely just to get it in on the first attempt and be done. And that will save you so much time if you know what direction you're going in and the angle you're going to take and how far off the probe you are. And it makes this procedure so much easier. And by this procedure, I mean every procedure where you're going to be sticking a needle into somebody. So just think about the pros and cons of all the angles you take. So say we're going at 45-degree angles. We're doing, essentially a central line. We're going in at an angle where I can get close to the probe, I can get it in, it's a relatively deep distance, my needle isn't that long necessarily. Say I'm doing an ABG. Sometimes I'll go straight down if I'm doing it by ultrasound, essentially just to get into that artery, know exactly where I am, and be then done with an ABG as opposed to, risking I think about 20% of the time I get venous blood. Even if I'm convinced I'm feeling artery and it looks like it's pulsatile, it's not worth the risk if you're just going to do it once to be done. And these super, super low angle ones, say like an EJ, just know the risks and benefits and know how much further the vessel is going to be when you're doing these different angles. And the odds of shredding the top, the odds of going through and through, and just know that they change with the angle you're going to take. So say this guy has a blood vessel. We want to stick some needles into it. You can't just think about that one tube. You got to imagine its directionality. So those textbooks are great. They show you a tube, but you don't know what direction the tube is going. It could be there, it could be this guy, it could be over there. And so how you set up and where you're thinking about pointing the needle will depend on the three dimensions, the actual direction the tube is going. And this is also true with ABGs. You can't just feel one point. Sometimes you have to know a direction you're going. Or for an IV, you have to know the direction the vessel is going, even if it's just by palp, so that you're not likely to hit a turn, you're not likely to punch through the back side of it. You just got to think about these. Of course, Riley shows up as I pull up an ultrasound picture. Don't just look at it in one axis. For any procedure, look at it in both axes because each of them adds information. One adds a lot of left to right information, great for depth, comparison, what are other things in the area I might hit. If there's an artery to the left and the vein is to the right, I would rather err to the right. I'm going to enter to the right. It tells me what am I going to go through. Is it muscle, which is going to hurt like hell? Is it fat? All these things are great in one axis. And the other axis I find very useful for the directionality. So sometimes with patients, I'll take the probe, get a long axis, and remind myself that that's the direction, and I'll either draw a line alongside it, or I'll position them so that that's straight to me. So that by like default, I know that I'm putting my needle in this direction. And that applies to ultrasound guided IVs, central lines, everything. You may even want to position the patient so that that straight line gets even straighter or is in a better position for you. So even before you stick the needle in, it's good to know where you're going so you can set the patient up.
There's a quick and dirty way to remember, as far as short axis versus long axis, where you put the selection marker, and 96, 9 o'clock for short axis. So relative to you, if you put the selection marker at 9 o'clock, if you move your needle that, this way, it'll look that way on the screen. And if you put your selection marker at 6 o'clock relative to you, as you go right down the middle of the probe, you'll see that needle go in the same direction on the screen. So just remember, 96, your scores, 96 and above, right? No, just teasing. So 96 is a, because it's confusing. You get everything set up, and then you put the selection marker at 12 o'clock, and you're expecting it to come from this direction, and it comes from the other direction on the screen. So that's critically important. The other thing I would say is that there's a little bit more of a learning curve with long axis, but it's well worth it. The problem with short axis is you can't see the sharp, dangerous tip as it goes through the tissues. And with long axis, you can, every millimeter of the way, you can see the dangerous sharp tip, and you can look and see valves, or at least the bulging areas of the vein. Oftentimes you can't see the valve itself, but you can avoid those bulging areas and find a nice strip of continuous vein, and cherry pick and pre-stack the deck in your favor of getting it on the first attempt. I think that's, we've all seen poke, eventually get it, pat yourself on the back, you got the IV. That's, in 2016, I just think that's wrong. I think we should really be focusing on getting in on the very first attempt, and this is what we're potentially doing.
And when in doubt, you can always poke the skin with a non-sharp object and see what moves around you. It's a way to give yourself left-right reference. So, talked about valves. Dun, 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 dun. That's a valve. So, in a lot of these procedures, things fail for the same 5 or 6 reasons in general. If you've set everything up flawlessly and it's a pure technical error, if it pops a little bit later, it's probably because there was a valve. So if you stab a valve, if you stab near a valve, it's less likely to be a long-lasting line. If things are too deep, so you're like, I'm gonna put in the ultrasound, get an IV, and I got this beautiful giant vessel, but it's 4 centimeters deep, you're gonna be putting it in just inside that vessel at a crazy steep angle, and it's gonna fall out. They're gonna sneeze or contract their muscle, and that's gonna pop right out. So if it's too deep, so know the depth you can get to with the tube that you have. Things dive. So people do a cross section, they see a beautiful target, they get way too close to the probe, they stick the needle in, and they're always sort of chasing this down diving vessel. So if it's diving, know that it's diving, start somewhere very, very shallow so that you're likely to get a portion of the vessel you can actually hit. So while these diving vessels are really annoying for a lot of vascular access, if you get it at a shallow point, it's actually nice. You can go a steep angle, get in, and when you lighten up the angle, it's going in the exact direction you want, and there's actually less resistance in the tubing. If the tubing has to take like a 90-degree angle to get into the vessel, it's going to add resistance to the line. If it's in the direction of where you're going anyways, you can get a lot more fluid through faster. And junctions. Junctions can be a big problem for, either you're butting up against the end of the V junction, or you're dumping into a section that just wasn't designed to hold all that much pressure. So we're going to end pretty soon. We're going to talk about some physics. That's a physics joke if you don't get it. So we all remember this guy, right? So I don't like equal signs. I like the proportional sign. It's more about what matters in the equation. That's good for people who like to make up equations. So I want to dump. GB wants to put 5 liters into our diabetic dude. And so some things matter, right? I can adjust the pressure. How are some ways we adjust the pressure? We've got a bag of IV fluid. Pressure bag. Anything cheaper than that? I could squeeze it. Anything even cheaper than that? That's manual labor. Hang it. If anyone's ever seen me in the Columbia ED, I'm on my tippy toes, like clawing at the hooks, like above the thing. I have no patience at all, so I'll hang all my IV bags on like the roof hooks and just dump water into people. So getting it high up, getting the pressure up, these are all great. Radius to the 4th. So people said, bigger tube, things go faster. True. The wider the tube, the more fluid you can get in. That's probably going to always be your biggest factor. It's usually not going to be the other guys. Viscosity. So am I jamming water into you or am I jamming blood into you? Blood is going to go slower. Take that into account when you're using a 22 gauge needle to fluid resuscitate somebody with blood. Not going to go so well. And the length. So I put a beautiful sheath in somebody and then I get this 15-foot line of IV tubing to then give them the blood. Kind of just undid all the stuff I did by putting the sheath in. At least there's less resistance, but if you can shorten the tubing, do it. Don't stack lines on top of each other if your goal is to get fluid in quickly.
So length is also very relevant another way. Central lines, triple lumens, are a bad way to resuscitate people because they are really long. You put a sheath introducer in because they're the biggest thing that's going to completely swamp any length issues. But if you just, if your purpose of gaining access is to get fluid into a person, you don't want a triple lumen. And if you think, well, maybe they'll need a triple lumen, they can do that in the ICU. But don't put that triple lumen in to resuscitate them. Put it in the peripheral line, put the fluid into the peripheral line, and then when you need something, if you need access for pressors, you can put it in triple lumen also or later. But because of that length factor. When the radius to the fourth is certainly a much larger factor, literally, but length is relevant in decision making very practically.
Yeah. And the gauge of the triple lumen catheter, each of the little triple lumens is like 20 something to 30 something gauge in general, so they're all tiny tubes.
They're quite that small, but they're, I think they're like 20.
It's a 16 and 18 and a 20, or an 18 and 20 and a 22.
Cool.
But they're long. So they're not comparable. They're not comparable to a
Yeah.
18, 20, 22, 16, 20 ID.
Got it.
They're 10 times long.
So there's this wonderful little chart you can get. It's also written on the back of every IV. And it tells you the gauge, the length, we have the long IVs, and we have the flow rate. And a lot of times I thought it was just like a fun factoid, be like, oh, you can look up the max flow rate you could theoretically do. And I finally figured out why to whom this actually matters. So if you've ever ordered a CAT scan and they say they have to have an 18 gauge, half the time that's just nonsense. Sometimes it's actually true. So when they're gonna jam contrast into you for a CTPE, or any kind of angiogram, for every patient size, there's a certain amount of contrast they have to get into the body. So if they have to get in 100 cc's of contrast, and they have to get it in over 4 seconds, that tells them their flow rate that they need to get this stuff in, and they may actually need an 18 gauge to do that. They may actually say that it's 120 mLs per minute is the flow rate they have to achieve to get a good quality study. Part A, it's helpful for them. But it may also be a safety thing. So at a high enough pressure, these things actually shear. The tubing actually pops off of that, let's say that pink section, the tube will actually break at that juncture point. That's the weakest part. And in theory, you could launch a catheter down into someone's bloodstream, and that's another contributing factor. So if someone asks for an 18 gauge, think about how big your patient is and do they actually need one. If your person weighs 35 kilograms and they say you need 18 gauge, you can say the person's like tiny, what's your max flow rate you need? And they'll often tell you. And you can say, oh, I put a 20 gauge in, that covers your flow rate you need. And I've used that argument in peds, and it's actually worked, where they want a certain gauge, and you say, that's not actually correct for this size person. They don't actually need it. It's also good to know this for relative comparison. So the Cordis does about 300, the specific brand does 300 milliliters per minute flow rate. So if I don't know where the sheath introducers are, but I know where a 16 gauge and an 18 gauge are, I'd rather just put those two things in and I get the exact same max flow rate. So it's great to stick a giant tube in someone's leg, it's very satisfying, but there are equivalents out there, and if your goal is to do a certain amount, it's good to know what the comparables are. So one sheath introducer is equal to 3 18s. So that you can make an argument for, you know what, I know you wanted me to put a sheath in, couldn't find it, or I'm not comfortable doing it, I put 3 18s, they all flow great instead, gives us the same flow rate. Something to think about. Boss man.
This is flow based on crystalloid though, right?
Correct.
Numbers might be a little bit different for blood.
It might.
It will be. Viscosity.
Very much slower.
Viscosity was an explosive factor. Blood is much more viscous than water.
And it would probably apply just as equally to the other size tube. So viscosity affects both.
Yeah, it's the same factor. And
Yeah.
everything.
Just to hit home what we were talking about with the triple lumen, look at the 20s. See there's two 20s there. You guys notice the difference, the length, 25 millimeter versus 30 millimeter. 5 millimeters of length lost you 5 cc's per minute of rate. And our triple lumens are 20 centimeters long. They're 200 millimeters long. And we're looking at a 5 millimeter difference there lost us 5 cc's. Don't resuscitate through a triple lumen.
Yeah. All right, we're gonna accelerate a bit. So which one is an artery, which one is a vein?
Blue one's in the artery.
Anyone know? No, you can't tell? You don't want to put a central line into the red guy? Come on, it's so obvious. You can't tell which one's which? This is fun. So when I started medical school, I looked up the data on how often we screw up. It's always an entertaining thing to look up. It was actually like 14% of the time. As of last year, 4 to 9% of the time, we're still stabbing the artery, and that's cases where people admit to screwing up. So imagine how high it actually is where people are still stabbing the artery. Boggles the mind. So I'm going to try to help clarify a few things. So color doesn't matter, right? Because you can flip the probe and get the color in the other direction. Veins are usually a little bit larger in this part of the body. Anyone can tell me where we are? We're in the neck. So it's usually a little bit larger when they're bearing down, when they have fluid in their body. It can be bigger. It can also be smaller. It's usually got a thinner wall, but there's a billion diseases that can change the thickness of your wall, or your ultrasound can be dropped 100 times and you can't tell the difference anyways because there's no resolution. So they're not absolutes. Some things are a bit closer to absolute. So ultrasound machines have the ability to put down Doppler. And I don't just do the waveform. So this tells me it's arterial waveform because you see a huge spike in velocity and then it kind of calms down. I often, if I'm not sure, I'll put the audio on, or if I'm teaching somebody, I'll put the audio on and listen. It sounds like a giant gushing artery. Swish, swish, swish. Helpful. Watching the pulsations. So you see the waveform, you listen, and you actually see the color flash on, flash off. It's pretty convincing that it's an artery. Other waveforms, like on the right side, that looks more like a vein. It's just more continual flow. Maybe there's some pulsation to it, but it's not convincing. And if there's an artery right next to it, it may be giving it a bit of mass effect, and you may get the illusion that there is some spike in velocity, but it will not be to 60 centimeters a second of blood flow. It'll never be that high in a vein, unless they have a giant fistula. And if all you do is look for the vein, you're gonna screw up. If all you do is look for the artery, you're gonna screw up. Look for both, convince yourself with evidence that one is one and one is the other, and separate them. Compare them. How are they different? And visualization, Doppler, listening, compressibility, the appearance of the vessel, you have to use all of these things, not just, look, it's red, it's left, it's bigger, it's larger. You can't pick one or two things. Because you don't want to be this 4 to 9% of people who's just stabbing someone's artery because you couldn't figure out the difference.
Justin, man, with your master of physics, you're ready to take your physics RDMS test now.
All right. Other fun fact before we start closing out, mass is conserved, if you didn't know that. Fun fact. So for people who have been stabbed, where do nurses like to stab their patients? There's pretty much only one place I see them go 90% of the time in like a new person they don't know, to stab right in the AC. So any patient who's spent a lot of time in a hospital or different hospitals, that has been stabbed into oblivion. So those things are gone. So all these big juicy guys up top, they're primers for the first round of where I'm gonna stab somebody, and they're gonna go. Secret, there are other vessels in your arm, good secret, they're like very small, and there's a bunch of them, but they don't tend to get recruited, and they just kind of hide out in the deeper tissues. So start thinking about moving up the arm, especially with ultrasound guided IVs. My money spot is right here, and this is why. So nurse A tries, kills that guy. Nurse B tries, kills that guy. Your attending wants to show off, kills that guy. What's gonna happen? Over time, when this guy comes back to the ED a few months later, and you're putting ultrasound guided IV, these guys are gonna be much, much larger. Because that blood has to go somewhere. Unless their arm is massively edematous and blue, and like there's vascular changes because the skin is all dying from vascular pressure, those other guys are probably being recruited. So people who have terrible access for a nurse to do by palp have phenomenal vascular access deeper in the body. And right here, it's all through fat. So most people I can get right here, and if you're gonna screw up, just keep moving up the chain. Maybe the intern tried here and stabbed into oblivion a month ago. Move a little bit higher up. And once people have been stabbed into oblivion where all their good vessels are gone, there's a vessel somewhere in their body that has gotten larger. It may be over the elbow. I found a big juicy one. I found one right in the middle of the wrist. Places you just wouldn't expect. So go, if they've been stabbed into oblivion, look around. You can probably find something that's phenomenal. The more they get stabbed, the bigger they get. So people love research. I've even done my time. It's terrible. There were 2 cool studies I was reading about. Because whenever I tell patients, I'm like, hey, I know a bunch of nurses try to put an IV in you, and I know you're miserable, and I know you hate everybody, and this is the 15th attempt, but this one will hurt less. It will take longer to set up, but I'm much more likely to get it in, and we can give you pain medicine afterwards. And you have to make a negotiation for why you're going to do this line when 14 other people have stabbed them and missed. So one, you got to be super confident, because they're not going to let you try unless you're super confident. And that in general, if you have the time, practice on people for whom you probably could get a regular IV in. Practice on them. It hurts less, my patients tell me. It's more comfortable for them. And them being able to see what I'm doing and me talk through what I'm doing makes them feel better. So they surveyed all these patients and asked them about ultrasound guided IVs, and people, like, I think it was on a Likert scale 1 to 5, the average for a regular IV was like 2.5, and it was 4.5 ultrasound guided IV. They felt like you were giving them superior care because you were using technology. Instead of blindly stabbing around, you were thinking about where you were going, you were considering different options, and you get it in on the first or second attempt, and you avoid things like muscles, nerves, other things that are going to hurt them. So patients loved it. And the other cool thing I found was, in a lot of emergency departments 10 years ago, if you couldn't get a line into somebody who wasn't critically ill, dying, they should probably get some sort of central access. But if they're not critically ill and they're being admitted, back in the day, apparently people used to put in a lot of central lines because they needed some sort of access. And if no one can get an IV in them, can't be admitted to the hospital, can't be getting an insulin drip, can't get these other things without access, so they got central lines. So this one ED looked over 10 years, and as soon as they started getting ultrasounds and people were doing ultrasound-guided IVs, the number of non-critically ill patients who got central lines, PICC lines, stuff like that, dropped by 80%. So less infections, less torturing of your patients, just because you could advance the type of access you can give them with a simple tool. I thought those were fun facts. All right, we're gonna end with 10 minutes to spare. I'd like to thank my wonderful mentors, Leah and Jared, who just guided my soul. It was great. If you guys have any questions, let me know. Otherwise, get some coffee and hang out. Do your surveys.
Give them some feedback.
Feed the back. Oh, we can actually pull up how to do feedback. All right, nypem.org. So if you guys scroll down, there's this thing called conference evaluations. Nope. Oh, look at this. There's this cool dude here. Steve McCoon. I'm doing my evaluation, so evaluative. Thank you.
That was excellent. I had it right. That was excellent.
How can we learn better stuff? 30 seconds to your evaluation. I just did it.
I could have told you to go buy the boot on your own, go pay $1,000, have fun. I'm just like, whatever. What is this?
I forgot I was going to throw candy, but I actually didn't feel confident in my ability to accurately throw candy. So I peeled off.
This
I had a philosophy.
That could have created some ocular trauma.
Help yourself. I figure I'll leave it for the next speaker still.
Yeah. Great job, man.
I mean, I teach better by showing people how to actually do stuff. So standing and talking in front of a screen is always my worst skill set.
Hit that apart.
Thank you.
I'm gonna go.
If you guys have your slush fund, I'll collect that as well.
It's 25.